A continuación vamos a conectar unas cirugías en vivo. Tenemos una colecistectomía laparoscópica desde Milán, Italia, que están en este momento ya preparando la conexión. Y acá en quirófano tenemos una hernia inguinal y una nefrectomía parcial. ¿Podemos conectar con quirófano? Luigi? Can you hear me?
Yes, I can hear you.
Hello, Luigi. This is Alberto Rancati from Buenos Aires, Argentina. We are trying to connect with your OR. Are you ready now?
Okay.
Okay.
I'm actually not there, so Ludovica Baldar is actually doing the search.
Yes. Hello.
I'm just following you from here.
Perfect. Ludovica, is she connected?
Yeah.
Okay.
Yeah, can you hear me?
Sì, buon pomeriggio. Come stai?
Buon pomeriggio. We are very well, thanks.
Okay. Can you tell us what we are seeing now?
Yes, sure. We just started the procedure. It's a laparoscopic cholecystectomy with an ICG fluorescent cholangiography. I'm going to release this adhesion here. And in the meanwhile, I'll tell you something about the patient and about the ICG dosage. Actually, the patient is a young lady with an history of symptomatic cholelithiasis. And is thin, about 54 kilograms, the weight of the patient. Push, thank you. We have a little bit of distension of the stomach. I'm sorry for this. So you can see that we can see clearly the ACG inside the gallbladder. And now we'll try to identify the common bile duct. It's here. Okay. And I think we have just here what we suppose for now to be the cystic duct. So I'm going to start to release the anterior peritoneum. You can see that the great majority of the ACG is inside the extrahepatic biliary ducts. And this is because we administered about 90 minutes before surgery a very low dosage of ICG. It is about 0.011 milligram per kilogram. So in this patient, for example, we diluted the ICG vial with 40 ml of sterile water, and we injected only one. Maybe we can go in Ellie in 75. We reduce a little bit the intention. This is because thanks to this low dosage, it's opal. Oh. Okay. With this low dosage, you have of clearance from the liver, and it's good because during the dissection you can see that where the ICG is really intense, it's by definition an extrahepatic biliary duct.
Yes, we have very nice image.
Good.
Hello, is Luigi speaking here?
A good image, even regarding the intensity of the light.
It's perfect.
Okay.
Okay, good.
Can I make a comment?
Of course.
Yes. Well, the result of this kind of view that we obtain with such a low dosage are very interesting because they come up from a study that Ludovica ran. So it's interesting because it can be applied to any patient because it's related to the body weight. The result of this study are published on surgical endoscopy. And the aim of this study is actually to try to obtain the lowest possible dosage in order to not having any fluorescence into the liver or very little fluorescence into the liver, a very high fluorescence into the biliary tree. So basically, with this was actually obtained when the injection was done 1 hour before surgery. That is something that we all know is the most common things to do, because the patient usually they come up in the morning. So basically, we give the injection according to the body weight.
Actually, we were on this
1 hour
study that
before
Professor Boni was talking about with a laser tower, but now today we are using the Rubina Storz, which is an LED system. So it is possible to use this kind of low dosage with both the technology, actually, from our experience.
Yeah, because at the very early stage of our experience, we were probably giving too much ICG to the patient.
So I
most
think
of the
that
image they will
agree
obtain.
that this is the cystic duct. I just wanted to see that if you can see any part of the duct, but I think the anatomy is quite clear. In the meanwhile, let me thank Professor Cassinotti, who's assisting me, and all our team, and Dr. Saletta, who's helping us as well. Okay. Okay, I think that we reached the critical view of safety. We started at a section above the Rubius sulcus, so if you all agree, I think we can clip and finish the procedure.
Yeah.
With the gallbladder dissection.
It's a very nice dry surgical field. Can I ask you a question to Dr. Loni about the adoption of the ICG in Italy, and at least in gastrointestinal surgery? How do you find that?
Do you mean how frequently it is applied in our country?
Yes.
Okay. Well, it really depends. I think it's very well spread. The adoption is not 100% for sure. I think that in the hospital that have the technology, there is a good adoption of it, but it's not still 100%. I don't know how much it is spread in your country, but I think it is increasing very well, because today all the laparoscopic systems that are on the market have the technology inside, and even some of the robotic system and robotic system have the technology, so it's spreading very well.
If I can add a comment on this, I think that for the perfusion
actually we keep the
bowel,
signal on even during the dissection, because with this low dosage, it is quite frequent to identify some little thin biliary duct that are running on the gallbladder bed. So if the image is like today, so quite clear, we keep the signal on. And then we have the final check in with the monochromatic signal at the very end of the dissection.
Hello, can you hear me?
Yes.
Yes. Well, just commenting about the use of ICG in Italy, I had to say that for bowel perfusion, I think that there is a very wide usage, especially for colorectal, as well as for the lymph node dissection in gastric cancer.
And regarding the use of ICG during laparoscopic cholecystectomy, actually we use for all cases of laparoscopic cholecystectomy. Sometimes when we do congress courses, a lot of people ask that say that it's useless for elective cases, but you never know when you can be in trouble or when you can have some accessory duct. Yesterday we were doing quite simple case regarding the history, and there was a big accessory duct just behind the cystic duct.
Yeah. Thank you.
So it's better to have in 100% of cases.
Okay, Ludovica, we are connected also with Luigi. but I think that they are...
Yeah.
yes, so now, Luigi, please finish your comment.
Yes, I just... well, yeah, what I was saying that is for bowel perfusion and for lymph node dissection during gastric cancer that is quite widespread. For gallbladder, actually, I have to say that, and I'm a bit disappointed for that because Ludovica just explained very well the reason for this disappointment is actually the usage is quite limited. And because people always think, oh, you know, if I have a simple gallbladder, I don't really need it. But Ludovica explained very well that unfortunately the common bladder lesion are present even during simple, let's say, simple cholecystectomy. And on top of that, you never know when a cholecystectomy that's supposed to be simple then becomes, you know, to become difficult. And I still, you know, we are a transplant center for liver surgery. And I can tell you that only us in that hospital, and we are 4 hospitals in my city that do transplant surgery. Only us, we do between 3 and 4 cases of liver transplantation every year for common bile duct lesion doing laparoscopic cholecystectomy. So I think that the image that you saw today and the surgery that Ludovica did, you know, it's almost impossible to make a major lesion to the common bile duct if you have this kind of visualization. So I think that actually there should be, you know, there is a need for increasing the adoption of fluorescence cholangiography, even in Italy, where it's a country that probably, together with the United States, is one of the countries where a fluorescence uptake is actually the highest. Definitely, probably is the highest in Europe.
Thank you. Thank you. Thank you, Luigi. Wonderful technique, very delicate maneuvers, and a very dry surgical field, nice images. So thank you very much. It seems amazing how you can detect all the elements and make a safe surgery and in this record time. So thank you very much. We are now switching to another operating room here. So thank you, Ludovica. It has been a wonderful experience to see you in the OR.
Thank you so much for the kind invitation. Thank you.
Thank you. Thank you. Bye-bye, Luigi. Thank you.
Bye.
Bye-bye. Have a good day.
Thank you. Thank you for being here.